Welcome to This Week in Orthopedics. This week we're covering 10 notable papers spanning the surgery versus conservative care question in foot and knee degeneration, joint preservation and arthroplasty durability across hip, knee, and shoulder, and 2 spine papers that challenge how we read imaging and plan alignment. Let's dive in. We start with the oldest question in our specialty. Does the operation actually beat time and patience? In Annals of Internal Medicine, a single-center Finnish randomized superiority trial did something that had never been done in hallux rigidus. It compared first metatarsophalangeal joint arthrodesis directly with watchful waiting. 90 adults aged 40 or older with radiographically confirmed grade 1 to 3 disease, symptoms for more than a year, and walking pain of at least 4 out of 10 were randomized 1-to-1, and 89 of the 90 completed 12-month follow-up. At a year, mean walking-related pain was 1.3 in the fusion group versus 5.7 with watchful waiting, an adjusted difference of 5 points, which is roughly 3 times the pre-specified minimal clinically important difference of 1.7. That is an unusually large effect for an orthopedic trial, and it moves first metatarsophalangeal fusion from the category of procedures we assume work to procedures with randomized support. The caveats are that this is one center, one surgical technique with lag screw and dorsal plating, and patients with type 1 diabetes, rheumatoid disease, or hallux valgus over 15 degrees were excluded. So generalize with care, but do stop framing this operation as optional pain relief of uncertain value. Contrast that with the knee, where 2 papers in Knee Surgery Sports Traumatology Arthroscopy paint a more ambiguous picture. In a prospective longitudinal study of 64 patients with acute medial meniscus posterior root tears managed non-operatively, symptoms improved dramatically. Pain scores fell from about 7.6 to 1.3 within 6 months and stayed there. Yet the joint deteriorated on imaging over the same window, with Kellgren-Lawrence grades worsening, joint space narrowing from 3.5 to 2.9 millimeters, meniscal extrusion progressing from 3.1 to 4.3 millimeters, and femoral and tibial about 3/4 stayed non-operative. The roughly 1 in 4 who elected surgery had more varus at baseline, 6 degrees versus 3.7, and a hip-knee-ankle angle threshold around 5.5 degrees predicted conversion with modest discrimination. The practical message is that feeling better is not the same as being structurally protected, and alignment belongs in the conversation when you counsel these patients. Alongside that, a Level 1 meta-analysis of 6 randomized trials and 551 patients found that intra-articular autologous adipose-derived mesenchymal stromal cell injections for knee osteoarthritis reduced WOMAC totals by roughly 8 points at 3 and 6 months, and lowered pain scores by about 1.5 points out to 12 months, with no significant excess of adverse events and rare serious events. The authors are appropriately restrained. Comparators, blinding, and cell products were heterogeneous. Stromal vascular fraction was deliberately not pooled, and there is no evidence of structural disease modification. So symptomatic benefit across a class of products, not validation of any one branded therapy. Our second theme is durability, which joint preservation choices actually change the long-term trajectory. In the American Journal of Sports Medicine, a systematic review and meta-analysis of 10 studies and 2,730 hips compared arthroscopic labral repair with debridement for femoroacetabular impingement. Modified Harris hip scores were statistically indistinguishable, and observational cohorts showed no difference in hip outcome score domains, but the single randomized trial favored repair for both daily living and sport-specific scores by roughly 10 to 12 points, and pain scores favored repair at 5 years or beyond. Most importantly, conversion to total hip arthroplasty occurred in 3.5% of repaired hips versus 7.4% of debrided hips, a risk reduction of about 44%, driven entirely by the long follow-up studies. Note the internal contradiction the authors flag. Design matters here, and the observational data dilute a signal the randomized data show. A companion American Journal of Sports Medicine paper gives us 15-year data on meniscal allograft transplantation in 160 patients, median age 28 at surgery. Graft survival was 84% at 10 years, 76% at 15, 69% at 20, and 52% at 25, Genuinely useful numbers for consenting a young patient. On univariable analyses, nothing predicted failure, but after adjusting for age and cartilage grade in the transplanted compartment, female sex emerged as a significant predictor of graft failure, even though patient-reported outcomes did not differ between men and women. Treat that as a hypothesis to explore, rather than a selection criterion, but do use the survivorship curve when you set expectations. Staying with durability but moving to implants, Acta Orthopedica reports a 5-year radiostereometry cohort of 397 knees, asking whether low bone mineral density predicts early tibial implant migration. Across cemented and cementless total and unicompartmental knees, 1-year maximum total point motion differed by no more than about 0.2 of a millimeter between patients with a T-score at or below -1 and those with normal density, and every confidence interval crossed 0. The odds of continuous migration were also unrelated to T-score. This is a negative study with wide intervals and small subgroups, so it is not a license to ignore bone quality. But it does argue against using a dual-energy X-ray absorptiometry T-score alone to steer patients away from cementless fixation. On the shoulder side, the Journal of Shoulder and Elbow Surgery published a systematic review of 10 retrospective studies identifying 11 significant risk factors for instability after reverse total shoulder arthroplasty, including male sex, younger age, opioid use disorder, depressive disorder, revision surgery, non-union, rotator cuff disease, prior subluxation, absence of subscapularis repair, cemented humeral stems, and lateralized glenospheres beyond 9 mm with loss of compression the dominant mechanism. The evidence is level 4 and vulnerable to confounding by indication, so the authors rightly call it hypothesis generating, but the psychosocial and substance use factors deserve attention preoperatively, not just after the first dislocation. That pairs neatly with a multidisciplinary guideline in Acta Orthopedica on primary traumatic anterior shoulder dislocation, which recommends imaging before and after reduction, a biomechanical reduction technique without analgesia where feasible with procedural sedation reserved for failure, about 1 week of relative immobilization, then early physiotherapy targeting function, coordination and proprioception, with primary surgical stabilization discussed in patients under 40, contact athletes, and those with significant bone loss. Most recommendations rest on low-grade evidence supplemented by expert opinion, which is itself worth knowing when you quote them to a patient. Our final theme is spine, where 2 papers in spine both tell us our usual metrics may mislead. A multi-center prospective cohort of 721 patients undergoing decompression for cervical spondylotic myelopathy tested the long-held belief that intramedullary T2 signal change predicts poor recovery. Signal change was present in 77% of patients, and while it correlated with worse preoperative upper limb pain and numbness, and with a greater C2 to 7 angle, after adjustment for age, sex, symptom duration, alignment, range of motion, diabetes, and smoking, its binary presence was not significantly associated with worse 2-year Japanese Orthopedic Association scores, recovery rate, quality of life measures, or complications. In other words, a bright cord on T2 should not by itself lower the expectations you set. The second paper is a retrospective multicenter analysis of 516 short-segment lumbar fusions, showing that global alignment can hide segmental undercorrection. Using a pelvic incidence minus lumbar lordosis mismatch under 10 degrees, 83% of L5S1 fusions looked aligned. Using segmental lordosis targets, only 42% did. At L4S1, the figures were 72% versus 34%, and segmental criteria identified worsening in 44 to 55% of cases versus 12 to 22% by the global metric. At L4-5, the 2 measures agreed exactly. Anterior interbody approaches and greater preoperative segmental lordosis predicted restoration. The takeaway is concrete. When your fusion includes L5S1, add segmental lordosis targets to your plan, because a normal mismatch may simply reflect compensation elsewhere. If you only have time for 1 paper this week, make it the Annals of Internal Medicine trial of first metatarsophalangeal joint arthrodesis versus watchful waiting. It is the first randomized comparison of this common operation against the natural history of hallux rigidus, and the effect size is large enough to change how you counsel patients in clinic tomorrow. Here are the key takeaways from this week in orthopedics. First metatarsophalangeal fusion clearly outperformed Watchful waiting for painful hallux rigidus at 1 year, with a pain difference roughly 3 times the clinically important threshold. Second, in medial meniscus posterior root tears treated non-operatively, symptoms improve while the joint deteriorates, and varus beyond about 5.5 degrees flags patients likely to come back for surgery. Third, adipose-derived stromal cell injections for knee osteoarthritis give symptomatic benefit without excess adverse events, but no evidence of structural disease modification and no validated standard product. Fourth, labral repair rather than debridement in femoral acetabular impingement, halved conversion to hip arthroplasty over longer follow-up, while meniscal allograft survivorship falls from 84% at 10 years to about half at 25. Fifth, 2 negative or null findings worth internalizing. Low bone mineral density did not predict early tibial implant migration, and T2 cord signal change did not independently predict worse 2-year myelopathy outcomes. And finally, in short segment lumbar fusion, including L5S1, a normal pelvic incidence minus lumbar lordosis can mask substantial residual segmental malalignment. That's your roundup for this week in orthopedics. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And if you have a paper you have been meaning to read, upload the PDF or paste any link at audioscholar.cc. We will turn it into audio like this one in any of 31 languages. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.